I've called the session, pardon me, closing the ABF loop because I think it's important that people have some degree of understanding of how the whole system works. Many of you, as I understand, are from hospitals or local hospital networks or districts, whatever they're called. Your work involves supplying much of the data that IHPA rely on and that I rely on in making payments. You probably regard all this form filling and data provision as a pain in the colorectal system, or whatever not sure what the DRG is for that. But I think it's important you do get some understanding that it is a loop. What you do in terms of supplying information does feed back into funding at the jurisdictional level, at the LHN level, and at the individual hospital level. So it's very important, well, certainly to get the information correct, but I think it's also important to get a bit of an understanding of how it works. I seem to have knocked the... I'm also conscious that the worst speaking time anybody can have is immediately before lunch. You don't want to stand between a hall full of delegates and the buffet out there, so I will try and be as brief as I can. Look, ABF in a sense is nothing new. We talked about Victoria introducing it 20 years ago, but if you go back in New South Wales history, it actually goes back to the Rum Hospital days. The activity was funded by rum concessions. So the more activity you had, the more you drank, the more fees you generated that went into healthcare when your liver was shot. So there was activity funding back as far as the early 1800s in one sense. That's just a brief history of how hospitals may have been funded. You can see in 1945, and this was after the Commonwealth basically took over income tax powers from the state and started the process of making a significant regime of grants back to the states. But at that time in 1945, they would fund hospitals or fund states for hospital care based on 6 shillings per occupied bed day. So, there's been a flavour for many years. Sorry, I've gone the wrong way again. So what I want to talk about is the National Health Reform Agreement and what I do as administrator, supported by the National Health Funding Body, which is a fairly small group of about 20 people, very, very dedicated, who do all the detailed work that I rely on in coming up with payments to the states. The agreement was signed in 2011. It was an initiative under the Kevin Rudd regime. It followed a long process of negotiation between the Commonwealth, states and territories. And it introduced a whole regime of new arrangements between states and territories. I've got up there it was financial arrangements, but it went a lot further than that. It went to organisational structures within states and territories. It went into transparency and accountability. So I won't go into that in detail in the time I have, but it was more than just financial arrangements. The one thing that is important to understand, though, is it did confirm state and territory state and territories as the managers of their public hospital systems. It doesn't give the Commonwealth or me as funder any role in telling states how they should manage their systems, despite what some states think. The agreement established a number of new Commonwealth and intergovernmental agencies: the Independent Hospital Pricing Authority, the National Health Funding Body, me as administrator, the National Hospital Performance Authority, and the Australian Council on Safety and Quality in Healthcare. But most importantly, what it did do is confirm activity-based funding as the norm for allocating resources to public hospitals. And not just Commonwealth money, but also a strong expectation in the agreement that states would deliver funding to their LHNs, local hospital districts. They're called different things in different jurisdictions, but it would be on a price times quantum of service basis. The new funding arrangements involve that most hospital services would be funded on an ABF basis. Tony mentioned block funding, covering teacher training and research, small rural hospitals, etc. There's also a public health component, but by far the greatest proportion of money coming from the Commonwealth through the National Health Funding Pool is for ABF. The agreement provides that funding is to be on the basis of a calculated NWOW times national efficient price basis. Obviously the Commonwealth doesn't fund the full cost, so that is discounted, if you like, down to the Commonwealth contribution rate. And the states and territories that have funded their hospitals on an activity basis, but able to determine the amount so provided. There were two transition years, 2012-13 and 13-14, where the total going to each state was the same as it would have been under the previous SPP agreement. The distribution within the states to LHNs could vary according to activity levels, but the total didn't change. So if you produced more NWOWs in either of those years, all it did was decrease the amount the Commonwealth contributed for each of those, so that the sum still came to be the same. And that was really to give a couple of years of transition to enable states to get a handle on ABF funding. While it had been in place in some states for up to 20 years, there were some states that it would have been a struggle, or it would have been very difficult for them to implement a full ABF system from 1 July 2012. The agreement also provided a number of funding guarantees by the Commonwealth that I'll come back to shortly. The objectives of the agreement, look, I won't read all that out, but there's a couple of things that I think are important, particularly about improving the transparency of public hospital funding, and I'll come back to the range of reports that I produce. But it also involved the establishment of local hospital networks, which replaced various other arrangements the states and territories had in place, but to improve local accountability and responsiveness. Well, what is the National Health Funding Pool? It's really just a collection of Reserve Bank state pool accounts for each state and territory. So there are 8 state pool accounts that the Reserve Bank holds. All Commonwealth National Health Reform funding, that's ABF and other, is paid into these accounts on a monthly basis. That's done by Commonwealth Treasury. It occurs on the 7th day of each month. The money goes in and is then paid out to jurisdictions and their LHNs. I advised the Commonwealth Treasurer of the amounts to be paid into the pool for 2014-15, which starts in a week and a bit. That advice was given to the Commonwealth Treasurer on Friday, with copies to all state ministers. It was roundly 14 billion in 2013-14. In the year about to start, it'll be around 15.3 billion. So that's the Commonwealth NHR funding. The states also contribute their ABF funding into their state pool accounts, and that's roundly 20 billion. So from that you can see that the majority of funding for hospital services continues to be provided by states and territories rather than the Commonwealth. Each state's non-ABF funding, so that's for block or any other purposes, is paid into a state-managed fund that it's required to set up. And that's roundly $4 billion in the year just gone. So once the money goes into the pool, it's then paid out by me, out of each of the state pool accounts held by the Reserve Bank, according to the instructions of the relevant minister or his or her delegated person in the department. But that payout of the Commonwealth money has to be in accordance with my recommendations or my advice to the Commonwealth Treasurer. So my advice to the Commonwealth Treasurer is for each jurisdiction, this is the amount, and it should go to these LHNs and for these services, if you like. So while the state then directs me how to pay it out, that's got to be in accordance with my advice to the Commonwealth Treasurer. So in the year just about to finish, I'll be paying out roughly $32 billion to local hospital networks. And there's roundly $2 billion paid out for other services, block and public health. I don't know how well that shows up there, but you can see the two main receptacles of money are the National Health Funding Pool and the state managed fund that each has. And the two biggest flows from the Commonwealth Government, activity-based funding goes into the National Health Funding Pool, as does block funding and public health funding. So that's the total of NHR funding to states and territories. The states put their ABF funding into the National Health Funding Pool, and they put their block funding into state managed fund. The Commonwealth block funding goes in there to start with and out. Now, you're not going to be tested on this. It will be in the documents that you get. But just to show that it is a fairly complicated process in terms of the flows of money. But really, there's only two or three main flows. ABF funding from the Commonwealth and the state goes into the National Health Funding Pool and then goes out to LHNs or third parties on their behalf, which might be laundry services, or it might be departments themselves for things they pay on behalf of LHNs. There's also arrangements in place for reimbursing states if I always use the example, I come from New South Wales, I'm in Melbourne today. If I step out at lunchtime and get run over by a bus and end up in a Victorian hospital, ultimately New South Wales will pay for my treatment here. The Commonwealth share will go via the pool. The state will ultimately reimburse, New South Wales will ultimately reimburse for the Victoria for the cost of my treatment. The pool funding process is that each year states provide the estimated activity for the coming year on an NWOW basis by LHN and service category. So I take those NWOW figures, states and territories provide them twice, once in March and once in May. The first one is to feed into the Commonwealth budget papers. The second one is what I then use to advise the Commonwealth Treasurer. So I take the NWOW numbers states and territories tell me. I apply the various loadings. I apply the NEP that IHPA has determined. I calculate the growth component from one year to the next in terms of if states have increased their NWOW numbers. I apply IHPA's backcasting multipliers to ensure that the NWOW estimates for the 2 years, the year just finishing and the year coming, are on the same basis. There may have been changes in counting methodology, so to get the growth component, I have to make sure I'm comparing apples with apples. So after all that is done by the people in the National Health Funding body on my behalf, and various QA processes are applied, I advise the Treasurer, as I said, as I did last Friday, and that money starts flowing out to jurisdictions, to LHNs, it goes into the pool on a monthly basis from Commonwealth Treasury, and I pay it out daily, weekly, fortnightly or monthly as the individual state so determines. So most days I'm either at a PC or at a notebook or at an iPad. I carry one around with me every day. I have to go into a reserve bank account and pay out money to 50 or 60 LHNs in Victoria, 3 in Tasmania, whatever state is due to have payments on that day. And the Commonwealth payments are made on the basis of 1/12 of the yearly figure going into the pool each month. That's just a sort of a diagram of how the thing looks, the inputs, which I won't go through again, you can see that, but that's a diagrammatic representation of what I've just covered. To continue the process, states have given me their estimates of next year's activity, At any time during 2014-15, so I'm getting wound up already. At any time during the year, states can advise me that they're changing their NWOW estimates. So come October, September, December, a state can advise me instead of producing 1 million NWOW, it's going to be 1.1 million. I take that into account. I'll adjust the remaining months so that by the end of the year they will be funded according to their latest estimates of NWOW. Now, of course, that's all on an estimate basis. What happens then is we get the data that many of you are involved in, the patient level data that shows their stay in hospitals, their NWOW, their DRGs. We reconcile that to the estimates. So you might have given me an initial estimate of 1 million NWOW for the year. You might have revised that during the year to 1.1 million. I get all the patient level data. This is done on a 6-month and also an annual basis. And we put it through the IHPA calculator to come up with the NWOWs from that patient level data, and it'll come to say 1,130,000. So you will get paid, or the jurisdiction will get paid for an additional 30,000 NWOW. So it's very important that the coding and that the data that is supplied is as accurate as possible, because that is the data that feed into the ultimate determination of how much each jurisdiction and each LHN gets. Look, I'll jump over the rest of that slide. I don't think it's critical. Pool reporting. As I said, one of the objectives of the NHR agreement was to increase transparency. There are a range of reports that I publish on the publichospitalfunding.gov.au website. There's monthly transactions on monthly reports on all transactions through the pool. There's a national report, a report for each state and territory, and a report at the individual LHN level. I also do a quarterly report on states' compliance with the data provision obligations. States and territories are obliged to provide me with certain data from the agreement, and I report quarterly on whether they have complied with that. And I'll tell you, it's not 100% compliance, but you can read the details yourself if you wish. There's also an annual report which is quite detailed, and most of what's in there is prescribed by the legislation. That report is tabled in each parliament around Australia. Oh, sorry, it's supposed to be tabled in each state around Australia. I believe there is one jurisdiction that still hasn't tabled last year's report. It includes an audited financial report on each state and territory pool account, and a combined report. Okay, where to from here? And I'll try and be as quick as I can. Previous speakers have mentioned the changes in the Commonwealth budget last month. There are a number of guarantees set out in the National Health Reform Agreement. There's one guarantee that no state will receive less than it would have received under the old state specific purpose payment, the pre-existing grant system, indexed. Now that guarantee, the Commonwealth has announced it's not going to fund that guarantee. I continue to advise the Commonwealth Treasurer, this is the amount you are required to pay. I assume, and that's what I did last Friday, I assume he will ignore that component and only fund into the pool the amount relating to actual activity. There was also an agreement that the Commonwealth would fund 45% of efficient growth until 2016-17, so its component of the total NEP is increasing. Typically, states at the moment get around 30 to 40% Commonwealth funding, and they provide the rest. The growth funding is on a higher basis, but the Commonwealth has said the guarantee did indicate that after 2016-17, the Commonwealth would contribute 50%, so a higher contribution to efficient growth. That agreement or that guarantee has been finished. There's also a guarantee for $16.4 billion in additional funding to be provided over the life of the agreement up to 2019-20, and that has apparently gone by the board. Shane mentioned the new health productivity and Performance Commission to be established. Yet to know any details of that. I think the bureaucracy in Canberra is still struggling as to what they might want to have that commission do, and they need then to discuss it with jurisdictions. Look, just in finalising, I think it'd be a terrible loss if the benefits of activity-based funding were diminished by whatever changes may come into funding between Commonwealth and state. I think ABF is about much more than just what the Commonwealth gives to the state. I think if I were in the Commonwealth's shoes, I would want to make sure that regardless of the funding changes, there are incentives put in place to ensure that the benefits of ABF funding continue, the drive to benchmarking, the drive to improvements in efficiency and performance. I think those things really need to stay. But look, given that I've got the wind-up signal now, I will terminate it there.